Today's topic is arthroscopic rotator cuff repair. We're going to be looking at it from the surgical perspective. So the goal for today is to get us to have a little bit greater familiarity with the actual procedure of how a rotator cuff repair is performed, so that as rehab providers, we can have a more educated and more grounded approach to being a part of the interdisciplinary team. My name is Dr. Sarah Zigley. I'm a physical therapist. I'm not an occupational therapist. I'm an orthopedic clinical specialist. My background comes from UW-Madison in Wisconsin. I have an undergraduate degree in exercise and movement science kinesiology, and then my doctorate is from UW-Madison as well. My clinical background, I started off my career in sports medicine. I worked in the Milwaukee area at a level 1 trauma center and a tertiary referral center, specific in sports medicine. So I got a great exposure to a lot of high-level surgery, a lot of post-op rehab as well, which is pertinent to today's course. Following my time at Froedtert Sports Medicine, I joined the adjunct faculty at a doctorate of physical therapy program in Wisconsin, where I was a part-time instructor there as well. And I've also been an instructor in an adjunct capacity in Louisville, Kentucky at a university, both teaching Masters of Athletic Training students and Doctor of Physical Therapy students. I'm also a clinical practice owner myself. I started an orthopedic and runner's clinic in Louisville, Kentucky. And now my practice is actually located here in Wisconsin, where I'm presenting from, in Oshkosh, where I have an outpatient orthopedic practice with the runner's clinic. And I also am a consultant in the workplace. So I do industrial PT with on-site work, doing things actually for manufacturing companies and doing more direct to consumer physical therapy contracting as well. So that's my clinical background where I come to you from today. My contact information is available on today's slide that you're looking at right now. You are welcome to use my email address to reach out to me after today's course. That is sarah@bepreemptive.com, as my clinic is Preempt PT. So again, thank you so much for joining us today. I look forward to getting to speak to all of you. The course notes. So today's information is also available for you in PDF format. That'll be available on the Cheap CEU's website. So you go to continuing education courses, you'll click on the profession you're joining with, and then when you scroll down to today's course, it's alphabetical, so we'll be at the top. You'll hear or see that little icon right here that says click here to open notes. That will give you the pop-up for the PDF to download. That may be helpful for you as you can utilize those course notes on today's post-test that you take following the content. Then I would just like to bring us back to today's topic, and from here on, our content will be more specific to what we're actually talking about today. The course overview is that today we're going to be talking through a live real-time webinar for rehab professionals that'll examine surgical management of rotator cuff tears using the arthroscopic techniques. So we'll be doing a review of the literature related to the rotator cuff anatomy and pathophys. We'll be talking about classifications and diagnostics related to cuff tears, the different management strategies and options, surgical techniques and variations, and then of course, post-op considerations for those of us in rehab as well. The academic rationale for why we're doing today's course is that it's going to provide all of us with contemporary information on the cuff repair, some comparative analysis of the pathogenesis and management techniques to understand the rehab implications and maximize the outcomes based on the current research. Now, when we're looking at really the feet on the ground, the reason why we want to sign up for this, from my personal experience, dealing with a lot of rotator cuff repair surgical patients in my career, I always found myself getting a little flustered when I was talking to the surgical team about the actual surgical procedures and the implications that had for my patients. So when I worked in the hospital setting, I would have the privilege of walking down the hallway and addressing the surgeons directly when I had questions about precautions that a patient might have or a nuance of their specific surgery. And I always felt a little bit on edge when I would do that, the whole flush red skin, and I would do that. And I found that the more information I had and the better I understood the actual surgical procedure, the more confidence that I had in talking to these other professionals. So I feel like I would like to bring some of that confidence to all of us as rehab providers. Not only does it improve our confidence in the interdisciplinary team, It also allows us to make better decisions for our patients. If we understand the nuances of their specific surgery, then we can match those to their specific exercises and post-op rehab selections. So it's going to make us better rehab providers. And then on top of it, who spends more time with a patient than their physical or occupational therapist? Not many people, right? We spend hours and hours with these patients. So most of the time, patients are going to direct their questions to us as rehab providers. So this gives us a better toolkit to answer questions from our patients about either the pre-op decisions or prehab or the post-op process afterwards. So I think really there are a lot of different angles from which learning more about the actual surgical technique will help us as rehab providers. These are today's goals and objectives. Instead of reading them all to you today, they are available in your course notes. I will just acknowledge that all of these things will be in today's course. The disclaimer that we always have with providing you with continuing education is that the application of these contents are really at the discretion of the participants and need to be in accordance with your federal, state, and professional regulations. And we don't have any conflicts of interest either for the presenter or provider today. So just as a reminder, again, for any of you who have had a little time since being with us, the icon that says consider this with that little hexagon is essentially your little flag to let you know that the content on that particular section of the course is relevant for the post-test. So again, if you see that little hexagon, a little star for the slide, just to let you know that that information is going to be particularly relevant for our post-test. Then let's start to talk about the glenohumeral joint. So in order to talk about the rotator cuff and tearing of the rotator cuff, really we first have to start with the anatomy, the physiology of the structures really that are imperative for its function. So the glenohumeral joint, of course, by its structural function, is very, very loose and it doesn't have a lot of congruency. The shallow glenoid fossa and the large, broad humeral head lead to a natural amount of instability. Now, the reason that this is incredibly beneficial for the shoulder is because it allows us a lot of mobility, right? If we try to do a full 180 or 360-degree circle with our hip, we wouldn't get that same amount of motion because of the depth of the socket. But in the shoulder, since that cup is much more shallow, we have all of this motion. It's definitely a trade-off because with that motion comes the natural instability of the shoulder joint. That instability is largely offset by the stability created of the rotator cuff. So again, the rotator cuff being these four different muscles of the shoulder joint really are more of a continuous wrapping. I think that's one of the pieces that I took away in doing the background research for today's course is that although we think about these structures as being very distinct, right? We think about the internal rotators, the external rotators, the elevation muscles. Although we think of them as truly being very distinct structures, they are more of a continuous wrapping around the shoulder joint. So when we talk about them distinctly, there is some differentiation between them, but they do also have a lot more in common. So talking about the four muscles, we're going to be really emphasizing the supraspinatus, the infraspinatus, the subscapular muscle, and the teres minor. All of these filling the spaces created by the scapula. So we've got 1, 2, 3 muscles visible from the posterior surface. And then, of course, the subscap, which is kind of the add-on muscle that doesn't really fit the mold of the others from the anterior surface. So in order to talk about muscles and how they function, we really have to talk about their origins and insertions because that's going to tell us what kind of movement they're going to create. So of course, looking at the scapula, we've got the supraspinous fossa, which is going to be the home of the origin for the supraspinatus, and the infraspinous fossa for the home of the infraspinatus. The teres minor is going to come off of that section as well. And then we've got the subscapular fossa, which is going to be the home for the origin of the subscap muscle. So really the shoulder blade is the key component of the origins of these muscles. So when we're talking about rehab, for the rotator cuff. This really is the reason why we talk so much about scapular stabilization when we're looking to have optimal function of the rotator cuff. Because I think a good analogy, I use this a lot when I'm talking about the core or when I'm talking about rotator cuff strength. We need to have a stable foundation in order to create power and strength off of. If you are going to jump into a pool and you want to see how far you can jump into the water, you can either jump off the side of the pool or you could jump off of a floating, flamingo or a raft. You're going to jump farther from a stable side of the pool than you will from a flotation device. And the reason for that is because of the stability of the ground, right? So when we're looking to have muscle power and function, it needs to have that stable base. And our scapula is the stable base for the rotator cuff. Then when we're talking about the insertion, so we've got the origin on the scapula, the insertion, now we're talking about the proximal humerus. There are two key points of the proximal humerus that the rotator cuff inserts into. It's the greater tubercle, which is going to be the home for our supraspinatus, infraspinatus, and teres minor, and then our lesser tubercle for the subscap. Now, you may have already noticed that there was a little bit of a differentiation in my terminology. I said tubercle, and the slide, which said tuberosity. Those terms are actually used interchangeable. This is another point that I found interesting. Even when you reference the Holy Grail of Anatomy in the Netter textbook, those two terms are utilized interchangeably. So if you hear greater tuberosity of the humerus or you hear greater tubercle of the humerus, those two are genuinely synonymous. So either one is correct when talking about the insertion of the rotator cuff. If we look a little closer at each of these muscles individually, so of course, kind of the poster child for the rotator cuff, the supraspinatus. This one is going to be best visualized from the superior view, so kind of looking from the top down. It has multiple functions, of course, some of them being elevation, abduction. However, really the one that has the greatest role for us to talk about is stabilization. So it's going to stabilize that glenohumeral joint. From an innervation perspective, the suprascapular nerve is the one that's going to be responsible for function of the supraspinatus. Next, we'll talk about the infraspinatus. So this would be the second most commonly torn muscle of the rotator cuff. Its function, in addition to external rotation of the shoulder, is going to be stabilization as well. So you can see those muscles teaming up to really create that glenohumeral stability that we need in order to prevent dislocation with general daily activity. It shares an innervation with the supraspinatus as well. The teres minor would be considered the partner in crime to our infraspinatus because both of them do have a role in external rotation. The teres minor is really going to set itself apart from the infraspinatus by having the greater role at abduction of 90 degrees. So if we're talking about external rotation directly at our side, infraspinatus is thought to be more of the primary mover, where when we're at abduction of 90 and then going into external rotation, teres minor then has a greater role. This innervation is distinct from the first two because now we're talking about the axillary nerve. And then finally, our subscap, which is from the front side. Tears of the subscap are starting to become recognized at a greater rate, potentially due to evaluation differences, more so actually than functional differences. But the motion, in addition to stability that this creates, is our internal rotation. It does also have distinct innervation because the upper and lower subscapular nerves are responsible for the innervation of the subscap. We're going to jump back to exercise physiology. I wanted to just talk for a moment about muscle fiber types. So with the rotator cuff, we need to acknowledge the high amount of percentage of type 1 fibers. So type 1 fibers being our slow twitch are our aerobic or endurance style muscle fibers. So when we're going through our rehab process of the rotator cuff, we want to keep this in mind when we're designing exercises. Not only do we need to be maximizing the overall strength and ability to engage and fire these muscles, we also want to be acknowledging these slow twitch muscle fibers and addressing the endurance component of it. So again, why we're kind of jumping back into this histology style talk is because it's going to have implications on how we design our exercises. So a very mixed bag makeup of the rotator cuff muscles, both type 1 and type 2, making endurance a little bit more important than some other muscle types. Another kind of histological look is now at the tendon composition. So we've got the muscle components and the muscle fibers, but we also know that a lot of tearing and repairing happens in the muscle tendons. So let's talk about tendon composition, and this will come into play because of the healing process post-op. I don't love digging into the weeds a ton just for the sake of kind of going back and starting at this microscopic level. But if it has and when it has an implication for how I design exercise, then I want to talk about it. And in this case, tendon composition does. So tendon composition is going to change throughout the healing process. And what we want to know is that the innate collagen makeup is going to be type 1 for a healthy, normal tendon. 85% of the dry weight is type 1 collagen. Then there's other things, of course, like water and these other cell types, but really we want to be thinking type 1 is what we consider mature or normal tendon tissue. And speaking of the anatomy of the cuff, as I was reading through a lot of the operative research, some of the terminology that I was seeing wasn't something I had talked a lot about in rehab beforehand. So I wanted to share this part of the anatomy background with you as well, in case you also are not as familiar with it. The rotator interval is the one that came to mind. So the rotator interval is a region of the anterior superior shoulder that is often addressed in the surgical procedure. So the reason we care about this rotator interval is that it creates stability and it really helps to get the proper biomechanical function of the glenohumeral joint. So the borders of the rotator interval in this anterior superior shoulder are the coracoid process at the front, your supraspinatus tendon across the top, and the subscap tendon that comes up from the bottom, or kind of that superior angle. So we've got those three different components creating that space at the anterior superior shoulder. Within that space, we get the long head of the biceps, we get the coracohumeral ligament, and then the superior glenohumeral ligament and the capsule. So all of those things are really important structures at the front of the shoulder. Another structure in this area that's not necessarily the cuff itself is the bursa. So one of the things that I found was interesting is that although the shoulder isn't the largest joint in the body, it has the largest bursa in the body. So bursa is, of course, helping to dissipate friction. In this case, it's between the cuff and the acromion and between the cuff and the deltoid. So bursas, as a reminder, are innervated. So bursas are capable of producing pain. They also have roles in proprioception. So when we get a bursa that is pathologic, so anything greater than 2 millimeters being a thickened bursa, that can be a contributor to pain as well. So just thinking about the symptoms that a patient might have and the structures that are going to be involved in these surgical repairs, we do need to keep the bursa in mind because it could be a source of pain for our patients as well. Let's talk a little bit about how common rotator cuff tears really are. So, when they look at the population as a whole, we see that when we're looking at a demographic of 50 years and older, 30 to 50% of all people will be found to have a rotator cuff tear. Now, these aren't all symptomatic cuff tears, but this is an estimate of how many exist, whether or not they're creating pain. When it comes to how many of these are repaired, the estimation is that 75,000 cuff repair surgeries are performed just in this country, just in the United States each year. And this is not a number that's going down. The rotator cuff surgery numbers have been increasing, not just a little, but by 500% over the last 20 or so years. So we're seeing more and more cuff repairs. We're seeing plenty of these tears occur. So having this background knowledge is really helpful for us as providers because guaranteed if you're in outpatient orthopedics of any setting, you have either acutely worked with a post-op patient or you have seen someone who previously has been a cuff repair patient. So, who are the patients more likely to be in this category of the 50% having a cuff tear? Anyone over the age of 60 is at an increased risk. When we compare the population above the age of 60 and below the age of 60, it's 5 times more likely to have a cuff tear over the age of 60. And of your two shoulders, it's twice as likely to happen in the dominant arm. Now, this is more of a use-based risk, right? We get more exposures to our dominant arm just because of how we are more likely to utilize it. There are other potential risk factors such as BMI, diabetes, smoking, and hypertension. These don't have the same direct research backing behind them, but they do all have implications for tissue quality. And we know that tissue quality that is poor is less likely to sustain a healthy, continuous tendon structure when it's under trauma. So let's actually kind of talk about the mechanics of how the cuff tears. So trauma would be one of those, which is in our acute version of the circle. And then we also have chronic tears, so things that happen more degeneratively over time. I also want to acknowledge, though, the Venn diagram nature of this, which is there is the category we call acute on chronic. So people who have had a history of degenerative changes over time and have really what we would consider um, a low threshold acute trauma. So sometimes acute traumas will be things like skiing down a mountain, getting your arm or your pole stuck on a tree and ripping your arm behind you. That would be considered significant trauma to almost any cuff out there, right? But what if you were reaching for a gallon of milk and it kind of came off the shelf quicker than you thought? Maybe not considered a significant trauma, but in someone with a degenerative process in their cuff, that sub-threshold trauma might be enough to create a tear. So we call those the acute on chronic tears. And we'll dive into each of these a little bit more. In talking about the degenerative tears, or the ones that are chronic and happening over time, there are a combination of factors that go into determining whether the tendon will have this degeneration. Some of them fall into the intrinsic category, some are extrinsic. So, in the intrinsic factors, we're talking about things innate to the tendon itself that are going to predispose it to break down and having this partial tearing over time. The first of them is vascularity. So we know how in tissues throughout the entire body, vascularity and having the ability to have good circulation is going to make a big difference in the health of a tendon and the health of an overall musculotendinous unit. So if we have a decrease in rotator cuff vascularity, that is going to consequently put it at a higher risk for having this degenerative chronic tear over time. Metabolic changes can also make a difference. So we're kind of looking at the overall picture of the health of the tendon. Then we're talking about extrinsic factors. Extrinsic factors are going to be things that are going to bring external stress or load or compromise to the rotator cuff itself. So in this particular area, we're talking about the coracoacromial arch, so that really small space that we have formed between the head of the humerus and that acromion. There can be shear stress due to the narrow nature of that. Now, this is a place where we sometimes talk about the different formations of the acromion, because if you have a flatter acromion, you're probably going to have more space in that arch and decrease risk of this degenerative tear. However, if you're someone who has more of that curved or even hooked acromion, that space is going to become even more narrow. And that degeneration can just happen again more kind of insidiously over time. So the morphology of that coracoacromial arch and the narrow space can really create more shear stress. We also have repetitive microtrauma. So repetitive microtrauma can have many different forms. It can be occupational repetitive microtrauma if we're using our arms overhead over and over again, or even doing things that are smaller like desk work. But if we're rounding our shoulders forward as we're reaching and creating kind of that overall impingement over and over again, that can be repetitive microtrauma. We can also get the internal impingement of the shoulder. So as we were talking about kind of with the narrowing of the space, if we get impingement of that shoulder, it can be from that arthrokinematics not being really functional. So we should get the roll and the glide, where as we go to use our arm and we're starting to roll within that glenoid fossa, we should also get a associated glide to kind of keep it in the appropriate space without elevating. So if we get a lot of that drift up into the space, that can also compromise the tendon. So we've got both intrinsic and extrinsic factors that are leading to this degenerative process. Degenerative tears just being on a spectrum from the bursitis to the full thickness tears. There are different ways to progress over time. So one of the questions people really want to know is, if I have a partial tear now, am I likely to continue to progress into a bigger and bigger tear if it's not repaired? So if they looked at this from a study perspective, and they have found that there is some likelihood of progressing, but it's not everyone and it's not all the time. So partial thickness tears have about a 35% chance of increasing and growing over a 5-year period of time, where full thickness tears are more likely, and that's about 50%. The purpose of kind of going through this cycle is to show how a partial tear or a full thickness tear can actually lead to degenerative changes of the entire muscle component itself. So we start with disruption of the tendon. So disruption of the tendon is really referring to our tear. From there, we can get retraction. So when we get a tear, the actual muscle tissue can pull back, or what we call retraction, pull back away from the actual insertion point on the bone. When that happens, the muscle is less functional. So we can't create force generation when there's no attachment site on the bone. So then we're going to get this impaired force transmission. When a muscle is sitting stagnant, so it's not able to transmit force, over time it's going to atrophy. And this atrophy is actually replaced with fatty infiltration. So the muscle that began as healthy, strong muscle tissue, now that it's had a tear, retraction, disuse, atrophy, fatty infiltration, which just kind of perpetuates the cycle. Things like tear size and location can factor into how much of this cycle or how fast this cycle goes. Then we're talking about, on the other end of this, the Venn diagram from before, acute traumatic tears. So these are more likely in our relatively young patients. It can happen from these falls, the traumas that we gave the ski hill incidents before. I myself have slipped on black ice in the past week and had a very traumatic, or I guess acrobatic fall on the asphalt. Very lucky I did not tear a rotator cuff. Those types of things can happen as well. These are typically going to be your larger tears and involve your subscap. Let's talk about how we classify the different types of tears. So anatomically, we can just talk about which muscle is being torn. Is it the supraspinatus, infraspinatus, or teres, or is it the subscap? So location would be our first way of classifying. We can also talk about it from the terms of size. So small being in this 0 to 1 centimeters classification, all the way up towards massive tears, which would be greater than 5. So I'm sure if you've ever looked through an op report or have had someone come in post-operatively and it says it was a massive cuff repair, this is what they're referring to, this greater than 5 centimeter tear. We can also talk about it from the thickness and location, which is the Ellman classification. So how much of the cuff is torn through? Is it less than a quarter all the way up to more than half? And also the location. So articular sided, meaning the side of the cuff that is closer to the humerus, or the bursal sided, which is the side that is closest to the acromion. So there's actually a difference in rate of tear compared to the articular versus the bursal side. The articular side of the tendon is at increased risk of tearing because the actual tendon structure is different there. So this side is more likely to tear than the bursal side. You can also have intratendinous as another option, which would be location C. Pardon my French because I don't speak it well, but the Goutallier classification, that's going to be talking about the muscle and the tendon quality. So how much of this atrophy and fatty infiltration are we seeing? We want to be a classification of 0. That's normal, so that's the most healthy tissue. As we work our way down towards classification 4, that's when we see more fat than muscle. And then probably one of the most influential classification types in the surgical process is the tear shape. So we're going to spend a little more time talking about this one because we will go through this again in the actual steps of the rotator cuff repair. So crescent is the first one. As you can see, it kind of pulls down in this little half moon shape. These tears are typically more mobile, so meaning that the tissue can be pulled more easily and it's not retracted. It hasn't pulled back very far. So if you get to pick your rotator cuff tear type, this is the one you want. You want to have the crescent type tear. The second type is the U-shaped type. This one has more retraction. You can see it just pulled farther away from the bone. Otherwise, it's very similar to the crescent. Then there's the L shape, which has the tear in this orientation. It's similar to the U because there's retraction, but it's more on one margin than the other. And then finally, we've got this massive contracted type of tear, which doesn't really have good mobility in any direction. If you try and pull it, there's not much that it can give. And it can be either U-shape, longitudinal shape. It can be really any different differentiation. This is the one you want to try and not have if you were to get an influence on your type. In your office, what might these patients present like? Well, pain is probably going to be your first hallmark classification. It'll be at the time of injury, but it's also very commonly at night. So a lot of patients will report this pain at the end of the day, pain when they're laying down at night due to the kind of extension position that the elbow will draw the shoulder into when they're lying supine. We also tend to pay for what we play during the day. Actually, that rhymed a lot more ways than I expected. um, we tend to kind of be more distracted during the day. We get to the end of the day at night, and all we really get to do is feel the consequences of our activity for the day. Overhead is the classic or hallmark plane or motion that we're going to have that difficulty. And then the pain location itself, if you ask the patient, take one finger and point to me where it's hurting, they're typically going to say here, although anywhere down to the location of the elbow can be a common referral pattern. We were always taught in PT school, beware the primary care referral that says deltoid strain, because when people have pain down here, although we think of the insertion of the deltoid, really we're talking referred pain from a rotator cuff. Some things that you'll see will be the painful arc sign, where someone has pain as they're going up, and then eventually they'll actually reach a region where they feel better. Weakness and range of motion limitations will also be hallmark in a rotator cuff tear. We want to check for atrophy, right? It can tell us a few different things. So atrophy can give us an idea of an extent of a tear, but it also can give us a clue for some differential diagnoses. So we talked about the innervation for the different muscles of the rotator cuff. We want to make sure that we're looking at neurological related concerns, either neuritises or nerve injuries, but also it could just be a higher grade tear that has gone through these phases of atrophy. The clinical exam, typically when we're looking at range of motion, we'll see significant losses, but there are some patterns that go along with specific tear types. So when we see pseudoparalysis, and to define pseudoparalysis in this case, we're talking about an inability to raise an arm greater than 90 degrees. So it's not pain over 90 degrees, it's actual inability to raise the arm more than 90 degrees. That is more correlated with a cuff tear involving more than 3 or more muscles, or to have a supraspinatus tear that is accompanied by a full tear of the subscap. So if you're seeing that true pseudoparalysis, where someone has complete inability to raise their arm over 90 degrees, we should be thinking about this greater degree of tearing. I also just put on here the adaptation of the normal athlete, because when we're seeing range of motion deficits, either in internal or external rotation, we have to consider what a patient's baseline might be. So having practiced in sports for much of my career, we think about our throwing athletes or our overhead athletes. They often will have a actual compensation or overall an adaptation of their range of motion, where they will have increased external rotation range and a loss of internal. So if we're seeing loss of internal rotation, we might just want to inquire what our patient's background is to see whether this might actually be an adaptation that was for their sport. On clinical exam, when we're trying to really identify whether a cuff tear is the source of symptoms, we want to be thinking of not just pain, but also strength. Pain doesn't have a great sensitivity and specificity as an assessment tool, but strength actually does have fairly good sensitivity. Sensitivity from a statistical perspective, remember that means if it's negative, we can rule it out. So if someone does not have strength loss, it is less likely that they have a high degree of rotator cuff tear. There are special tests we can use in the clinic. None of these in and of themselves have great sensitivity and specificity behind them to identify a tear, but when we cluster them together, they give us a better sense of whether someone might truly have a cuff tear. For the supraspinatus, our empty can test, so our thumbs down position, our full can test being the same but thumbs up, and again, resistance in both of those. Drop arm test, where someone is taking their arm overhead and then they either help it down or don't want it to come down, abducted away from their body. Infraspinatus is going to have that external rotation leg test. So when you've got your arm out to the side, does it drift back in because they're unable to hold it out? Teres minor then biased towards the abducted position and trying to test it here. And finally, the subscap is going to be tested in that hand behind the back position. The differential list needs to be relatively robust when we're looking at the glenohumeral joint because there are a lot of different things that can happen here. We're in very close proximity to the cervical thoracic area. So when someone has shoulder pain, while many of the times it's going to be cuff, it's not always going to be cuff. So we need to be considering some of these other things like labral tears and biceps tendonitis. We need to be thinking about multi-directional instability if someone has laxity in the shoulder. Impingement can be common, arthritis can be common. We can also have issues like adhesive capsulitis. That frozen shoulder presentation really mimics an acute rotator cuff issue in that phase one. As they go through and start to progress into the frozen phase and the freezing phase, it's easier to differentiate. But early on, adhesive capsulitis might need to be on the radar. Calcific tendonitis is another one that really looks a lot like rotator cuff tears. But in the case we actually have a calcification or a calcific body in there, we may want to rehab that differently and actually use some of our modalities to try and break that down. We can have nerve entrapments. We can have pathology in the cervical spine. We can also have Parsonage-Turner, so that brachial neuritis or thoracic outlet syndrome. And finally, before we just jump into break, I want to bring up the different imaging strategies that we use to confirm our clinical diagnosis. So not only are we trying to identify, yes, we do indeed have a rotator cuff tear, the surgeons can use imaging to identify whether that tear is more likely to be a viable repair candidate. So that's going to be identifying the size, the fatty infiltration, and the retraction. So not everyone who has a tear is going to be triaged to surgery, and some of these questions can be answered with imaging. So MRI is really the first line imaging modality because it has good fixation, visualization, as well as soft tissue fixation, but it's also because it's really accessible and often reimbursed. So, right, we think about there are clinical reasons that a lot of decisions are made in healthcare. There are also logistical reasons. So MRI is often used for a combination of both of those. MRA is also an option for imaging of the rotator cuff. It actually has higher sensitivity and specificity than an MRI, but it hasn't replaced it as the first line option. Part of that is because of the injection logistics and reimbursement, of course. But in the case of a younger patient or after a repair, an MRA might be preferred. And then finally, ultrasound. Ultrasound is a nice option at times because it can be done bedside in a clinic and we don't always have to go off site and have it done. However, it does require a lot of technical expertise in order to really identify the tear. So in this picture, you can see the tendon is identified here. That's the infraspinatus one, and the humeral head being through here. So it doesn't have all of the osseous visualization that the MRI will, but it can tell us a lot and can be done kind of in live time. All right, let's talk about the clinical decision-making process related to whether someone should be treated conservatively or with surgery when they do have a cuff tear. So now we're going to assume that our diagnosis is related to a rotator cuff tear, and what do we do now? So the first option is those who should maximize conservative treatment. So talking about our non-op options, there are various things we can do for non-op. This can be things like PT, can be things like medication, it can be injections. Who should be the people that go down that route first or foremost? There are two different categories of people who should maximize conservative management. The first is those who are very likely to do well without surgery. So those who are likely to do well without surgery are partial thickness tears. They are more likely to see success with rehab. And also people who have atraumatic full thickness tears, but they're smaller and they have an intact anterior cable. These are groups that we would expect would do quite well without surgery. The other group who should also consider maximizing non-operative management are those who likely wouldn't succeed with surgery because they're not great candidates. So those are going to be large tears with those advanced muscle changes, so our greater amounts of fatty infiltration and atrophy, and degenerative changes in more advanced age. So once we get over 65 and 70, we may not have as much success with a rotator cuff repair. So those are times where we would consider really trying to optimize conservative management. So some of these management strategies, let's just dive into what they really look like. So for medical management, pharmaceutical management, we're talking about NSAIDs primarily. Those are really just for pain management. They're not going to change the outcome of the actual tendinous health, any of the muscular components of the tear, but they are going to help people feel better. So, in the case of really researching the use of NSAIDs for cuff tears, it's not really listed as a treatment, but it's a commonly used modality. To think back about how NSAIDs are working, talking about why is it that this is an effective over-the-counter and prescription pain reliever. Well, there are really two different versions. We've got the older non-selective NSAIDs, and then we've got the newer selective NSAIDs. Both of them are going to be COX inhibitors. So both of them are going to be taking that cyclooxygenase enzyme and trying to diminish its use. So we've got the non-selectives, both COX-1 and COX-2. Those are your ibuprofens, your diclofenacs and Voltarens, naproxens, the ones that we see mostly. But then there's also the ones that just specifically inhibit COX-2. Now, why would you choose one over the other? So COX-2 is the one mostly involved in the inflammatory process. So when we're selectively choosing to inhibit the COX-2, we're going to be addressing the inflammatory process directly. COX-1 is prostaglandins that are also related to other types of physiologic process in the body. So we see this also in things like the GI system and other organ systems. So when we're doing them selectively, there are some benefits to really targeting the inflammatory process. There are, though, significant things that we need to talk about in terms of side effects of the medication. So why would you choose one versus the other? Well, GI risk factors tend to be a big point of conversation with NSAID use. So there is a risk for ulcers and bleeding, GI bleeds, when we're using NSAIDs to high doses or for prolonged amounts of time. So this chart at the bottom helps to identify the risk of having one of these GI bleeds. The characteristics on the list involve age. So if you're over the age of 65, higher doses, having a history of an uncomplicated ulcer, or also using other medications at the same time. If you have none of these things, you're considered low risk for having a GI risk factor or GI bleed. If you have one or two of them, then you're in the moderate category where you're at moderate risk of having a complication from using NSAIDs. If you have more than two of them, or if you've had an ulcer before that's considered complicated, then you're elevated into high risk, and NSAIDs may be a drug category that may not be the best fit for your patient. When you have the selective NSAIDs, so this would be our COX-2 inhibitors, then there's an increased risk of cardiovascular complications. So that's part of the reason why we're not seeing the selective used universally, because there is a cardiovascular risk. Physical therapy is another conservative management strategy, one without as many side effects, or side effects truly that we're hoping for, right? Strength is a great side effect of physical therapy. So who are the candidates most likely to respond well to physical therapy? It's really those who have lesser degrees of impairment on initial eval. So less impingement signs, better ranges of motion, better tendon and muscular health, and overall not having as much atrophy. So patients who have less severe tears have better chances of doing well in PT. Relatively face value logistics to that. There has been, though, a great study done by the Moon Group. So the Moon Group is an aggregate of orthopedic surgeons from across the country who are all specialists in this field, who bring their data together and try and create greater effect sizes of their research. So one of the questions that they addressed was, can physical therapy effectively be used for degenerative rotator cuff tears instead of surgery? That was their overall goal, was to try and identify how many of their patients or how effective was physical therapy for degenerative tears instead of having to do an operative repair. The people that they were looking at were MRI confirmed atraumatic, so again, our degenerative tears, but full thickness tears. So these were degenerative, but bigger in size. And they had 422 patients in this group. This is the PT program that they put them through. It involved daily range of motion, so things like active assistive and active range of motion, scapular and postural things. They also did daily flexibility work, so they were stretching out the anterior and posterior capsule. They were doing strengthening 3 times a week. This was for both the rotator cuff and the scapular stabilizers as well. The physical therapist, who was at the lead of their care, also was able to utilize manual therapy and mobilization as needed. So if the physical therapist felt that they had an impairment in mobility, they were allowed to manually address that as part of the protocol. And then they were given a home exercise program that they could progress as the therapist felt they were ready. They did recommend that the patients used cold and heat, but they did not have them use ultrasound. So the only modalities used were ice and heat. So the original study duration was 6 weeks. So all the patients, all 422 patients with these rotator cuff tears, were put in PT with this program for a 6-week period of time. At the end of 6 weeks, they had an option. They could either say, I have achieved everything I need to achieve. I'm happy. I'm done. I want to discharge. That was group 1. Option 2 was, I feel like PT is working, but I'm not where I want to be yet, so I don't want to discharge. I want to keep working. That's option 2. And then option 3 was, PT is not working for me. I am over this. I want surgery. So they allowed patients to self-select the direction after 6 weeks. During that 6 weeks, the PT averaged about 8 total visits, so looking at 1 to 2 visits a week. Those who stuck around for the second 6 weeks of PT, they on average had about 7 total visits, so a little closer to 1 time a week. And these are the outcomes from that data. So after 2 years, only 26% of all 422 patients opted to proceed with surgical management. So what that tells us is essentially 75% of these atraumatic degenerative rotator cuff tears who participated in physical therapy opted to never convert to surgery because they were happy with their results. So what they have kind of extrapolated from this data is that it is very probable that people with atraumatic tears may be able to see successful outcomes without needing to convert to surgery. So just some thoughts on when your patients are coming in, having been diagnosed with a rotator cuff tear, and they're asking you and they're concerned about why they don't need surgery when their neighbor, their uncle, their cousin, their spouse all had to have surgery. This may be part of the reason why. Another conservative management strategy that you'll commonly see with people who have cuff tears are injections. So a common substrate that is involved in the injections is corticosteroids. Now, corticosteroids as a group is what we refer to as a cortisone injection. I always erroneously thought that a cortisone injection meant that you were injecting something called cortisone, when really it is a class of injectables. So when we're getting a cortisone injection, it could be dexamethasone, it could be Kenalog, which is triamcinolone, or it could be Medrol, which is the methylprednisolone. Really, it can't even be a cocktail per se of those. They've done studies to see, is one more effective than the other, and they've really come down to just surgeon or a physician, if it's a non-op provider providing this, their preference, what they have access to, what they've had training with. It tends to be pretty equivalent in terms of outcomes, no matter which cocktail is used. And we see that with these corticosteroids, typically the effects are lasting 6 to 8 weeks. We don't see oftentimes really long-term results. The injection can be done 2 different ways. We either call it blind or imaging guided. If you're having it done blind, anatomical landmarks are going to be what is directing the provider towards the injection site. Imaging guided is usually done with ultrasound. There's a, to me, fascinating study done that is looking at whether there's an advantage to using imaging versus doing it blind. And they did a control group. So they had imaging guided injection, they had a blind injection group, and then they also had a control group where they injected, for people with shoulder pain, they injected them into their glutes. So people were getting a hip injection or a butt injection for their shoulder pain as the control group. Fascinatingly to me, all three groups got better. So even those people who got a corticosteroid injection into their glutes had improvement in their shoulder pain. So what this tells us is the study is really not necessarily saying that people are getting the location correct with a blind injection. What I think really the research is more extrapolating to say is that even if we miss, it probably is still going to help in some way. So just kind of an interesting study talking about the accuracy and effect of corticosteroid injections. There is research on how many injections people can have or should have compared to some of the outcomes and risk factors that go along with it. What they found is that once you get to 2 or more cortisone injections, if you get a surgical procedure following that in the year following, you actually have an increased risk of complication or revision post-op. So if a patient is highly considering a conversion to surgery, they may want to kind of be judicious about how they utilize corticosteroid injections in the time preceding that. There are other things that get injected as well. So corticosteroids aren't the only one. They're probably universally the most common, but there are other options such as hyaluronic acid injections. I tend to think of these more in our total joint replacement candidates, people who are trying to put off end-stage arthritic surgical management, but there's also some research on using these same gel shots or joint gel shot injections in our rotator cuff population. So when they compare them to corticosteroids, they actually see that the satisfaction rates at 1 month are very similar between the two. They've also tracked them out as far as 6 months and have found that the outcomes are also similar then. So sometimes the difference really comes from insurance reimbursement, but when you're looking at the risk profile of these two, there may be some benefits to using hyaluronic acid. And then also platelet-rich plasma, so our PRP injections. These are injections that are starting to become more and more commonplace across all spectrums of medicine. I've seen them advertised in sports procedures. I've seen them used in tendinopathy types of cases. I think it gets used now in cosmetics. People can get PRPs for hair regeneration and cosmetic purposes. But in our case, we're talking about PRP to use those growth factors to try and enhance tissue repair of the rotator cuff. So they're taking a patient's own blood through a blood draw, spinning it down either using a centrifuge or a specialized machine for PRP, and then re-injecting that back into the tendon of interest to try and really jumpstart that inflammatory process. There are a lot of different ways that this is done right now. Sometimes we call it a little more cowboy, where a physician is really drawing the blood, spinning it down, pulling back in whatever kind of is left, and then doing the injection that way. Sometimes it's done with a lot of precision, where someone is actually spinning it down to a specific cell count, trying to make sure that there's a concentration that matches a specific goal. PRP at this point is a little bit variable in terms of how it's performed. So you might see a difference based on which providers you're working with. There's also not really a consensus on how the PT or the rehab is done post-injection for PRP. Some providers will have really specific protocols. Others are a little bit more loose. But from my experience, the most common is to have a period of NSAID restriction where they're not allowed to use any anti-inflammatories, with also a period of isometric only exercise, and then that's progressed to eccentric followed by concentric and full functional motion rehab. So I think that's really the most common, but we'll see how that evolves over time. There is also a group that doesn't really clearly fall into maximizing our conservative management options or having early surgery as being the preferred option. And that's this group on the slide here. So we've got a group of patients who would be under the age of about 62 to 65 who really it's more of an informed discussion between the provider and the patient on both their surgical and non-surgical options. And the ones that really are falling into this group fall into a few different categories. So one of them is going to be your acute on chronic tears that have their function fairly well preserved. So we've got this degenerative tearing underlying the issue. There was maybe a smaller acute precipitating factor, but when you look at their overall function, they're really not showing the major deficits that we see in some of the other greater issues with acute tears. So they may kind of fall into either category of repairing this or being able to try and maximize function with rehab. The other patients who fall into this category are those who have anterior cable disruption and those who have atraumatic but full thickness tears that are greater than 15 millimeters. So that greater size, greater than 15 millimeters, is more of that full thickness and bigger size. But the fact that kind of pulls it here is that it's atraumatic. So again, it was degenerative. They got here over time. These are patients who might not have a specific designation on which one they should do, and their surgeon might guide them based on their personal clinical experience. It might be more related to the specific morphology of their surgical intervention based on that tear type. Could have to do with the location within the shoulder. It also might have a lot to do with the patient's specific lifestyle. Someone who has higher demands on their shoulder may lean towards having it operated on. However, we've seen many people whose personal situations aren't conducive to surgery, whether they're a caretaker for people and aren't able to take the time off from lifting that would be required. Maybe they don't have the financial resources to either go through with surgery or to go through with rehab. All of those factors can really be a part of the overall decision, especially when you're in this category. And then the final group is those who know early on that surgical repair is going to be strongly considered. So this group is going to, again, have two different categories of who's going to fall into it. One of them is going to be those who really are likely to be strong candidates for successful surgery. Those are going to be the people who have age compatible with healing, so our younger patients really, and then those who have minimal muscle degenerative changes. So those who have better tissue quality are going to have more likely to get early surgery. The other people are those who really are not likely to have good success with conservative management only. So those are our acute traumatic full thickness tears and our acute on chronic tears with new profound weakness. These people are not really going to get the results they look for most of the time with conservative management. So if you are triaged into the surgical management group, are there any times where you may not be able to proceed with surgery because it's contraindicated? There are systemic reasons. So there are some people who, from a health and wellness perspective, shouldn't undergo surgical procedures, things like different cardiac conditions or general health. We might be talking about things like pregnancy Or in this case, specific to the shoulder, we'd be thinking about any active infections, especially on the skin in the surgical field, or if there's a lot of acne in that area because of the infection risk. A patient, before transitioning to actually showing up on surgery day, has to have a pre-op clearance. So this pre-op physical is typically going to be referred out to another provider other than the surgeon. That pre-op surgical physical is going to typically have multiple different components. Part of it is going to be just its baseline physical health and readiness. So someone might be looking at their general vitals, looking at their overall health and well-being. Some patients may need to have a more thorough cardiac evaluation. So this would be either an EKG or a chest x-ray. Some patients may need to have a lung function assessment. So things like respiratory function testing, especially in the case of our obese population. And then finally, lab tests may also be involved. They may need to get a CBC, like a blood panel, pregnancy test, because as we mentioned before, there might be timing considerations for that. Someone may not know their blood type if this is their first procedure, so that might be something that's needed, or potentially GI testing as well. So a surgeon is going to send the patient out for this pre-op clearance in order to identify that they are ready and healthy for surgery. Once that clearance is given and they have a date on the surgical schedule, then they're going to have some specific instructions that they need to follow in the couple weeks leading up to their procedure. So if we're talking about 2 weeks before, the recommendations from the surgeon will also involve avoidance of dental procedures. So if there's an emergency, they can still have them done. They would just require prophylactic antibiotics. This recommendation also actually carries through to the post-op period for about 3 months afterwards. Some surgeons will also have recommendations to avoid flu shots for about 6 weeks after or the 2 weeks before. These two are mostly looking at infection risk and immune response. So these are things that are commonly going to be recommended for the 14 days preceding a person's rotator cuff repair. 7 days before surgery, so in that 1 week leading up, most patients will be asked to stop any anticoagulants or any blood thinners, really so the surgeon has better ability to control bleeding intraoperatively. They will also often be asked to stop all over-the-counter herbals and supplements, and this recommendation mostly comes because of the lack of regulation in that industry, that a surgeon is and an anesthesiology team is not going to have a good understanding of really what's in someone's system if they're taking herbals and supplements just because they don't really know what's in them. Then the night before surgery, there's going to be no eating or drinking after midnight, and this is for anesthesiology purposes. Funny example of this, I guess it's not funny, it depends on who you're asking. At Christmas this year, we were talking with one of my cousins and uncles, and he said, yeah, I stopped at McDonald's on the way to my knee surgery, and then they canceled me. Said, well, yeah, anesthesia can't put you under if you just had a English muffin because of the aspiration risk. So people need to be able to be NPO, so nothing eaten or have been drinking since midnight the day before the procedure. I wanted to take a little time as well to talk about the surgical team. This is something that I personally have had experience getting to know firsthand, or secondhand, I guess you could say, over the past 2.5 decades, as my husband actually is an orthopedic surgeon himself. And the specialization that the orthopedics have, as well as the pathway to become an orthopedic specialist, I think is something that I really appreciated a lot more after knowing the full process. So I just wanted to touch base on this because then it'll help you to understand really who's involved in the process of the surgical procedure and what is their role. So of course, I think most of us would assume and understand that a surgeon is going to be part of the rotator cuff repair process. This is typically done by an orthopedic surgeon who is going to have done an undergrad degree in anything of their choosing. It really can be anything they want as long as they do the appropriate prerequisites, followed by a medical school training. This can be the MD program or the DO programs. Those are a 4-year training cycle. So for most people, assuming a 4-year undergraduate degree and a 4-year medical cycle are 8 years in by that time. Then following that, they will go into a residency. So an orthopedic residency is a match process done at the end of medical school, which puts them into a 5-year orthopedic surgery specific training program. During that training program, a surgeon's going to learn everything from spine surgeries to pediatric surgeries to trauma surgery, joint surgery, foot and ankle, hand and upper extremity, and sports and arthroscopy. So hopefully I didn't miss any. I think that was all of the subspecialties. But that's spent during that 5 years. So now that they're 13 years into training, they've gone through medical school, orthopedic surgery training, and have the option to practice at that point. In today's current landscape with orthopedics, it's very common for these surgeons to also do a subspecialty fellowship. So that's going to be training that is done in addition to an orthopedic residency program. Fellowships are done in just one of the subspecialty areas we talked about. So if you're having a rotator cuff repair done and you want the most advanced trained orthopedic surgeon with the most expertise in your procedure, you would be looking at having a sports trained or an upper extremity trained surgeon. So there is many times a generalist surgeon available who does rotator cuff repairs, but they might also do joint replacements and other things. Or you can have someone who is specifically trained in scopes and upper extremity soft tissue repair. And those are going to be your sports surgeons and your upper extremity surgeon. And these fellowship designations will be listed in someone's bio. So if you're trying to identify someone's training pathway, you should be able to do that on their websites most of the time. With the surgeon in the OR, there is typically a first assist. The first assist is going to be either a physician's assistant, nurse practitioner, role typically called a surgical assist. Could be a resident if you're in academic medicine, or a fellow as well. These first assists are going to be scrubbed into the case and actually helping with the jobs that are hands-on. So they're going to be the ones holding retractors, not in an arthroscopic case, but they're going to be the ones actually involved with any hands-on tasks. There's going to be a scrub tech in the case. They are going to run the back table of instruments and hand things to and from the surgical team. There'll be an OR nurse. The OR nurse is essentially the one in charge of the room. She's going to make sure that the patient is ready and draped and charted and all of the things that go along with the case in addition to the actual procedure. And then there'll be the anesthesiologist or a certified nurse anesthetist. So those professionals are in charge of the patient's vitals and making sure that the patient's anesthesia is under control, both put under and brought back out. There will also most of the time be a device rep in these cases. So a device rep is someone who is going to be an expert in the instruments themselves that are used in the procedure. They're going to make sure that the surgeon has the tools ready for them and available for them, and then also answer any questions related to the specific use of that tool or instrument. So as you can see, it's a very large and dynamic team that's in each and every one of these cases. I put in these pictures here of little kids in kindergarten and some old gentlemen hanging out at a sports field, because when I think about the surgical pathway and becoming an orthopedic specialist, it kind of starts when they feel this old, and by the time they finish fellowship, I think they often feel this old. So in talking about patient positioning, now that a patient is in the OR, how are they going to be prepped and draped in order to actually have this procedure done? The first most common one we'll talk about is the beach chair position. So as you can see, appropriately named for the way that the patient is laying, they're going to be more in an upright sitting position with their hips flexed about 30 degrees and their arm coming out of the drape. The patient's arm is actually just positioned at their side. There is an arm holder attached, which you can actually see here. That is going to put traction on the arm. So it's actually going to pull the arm to try and open up that joint space for the procedure to be performed in that subacromial region. The patient's head, which is behind here, of course, that is going to be positioned in neutral and then strapped down. And then as the surgeon prepares and actually performs the surgery, they're going to be standing behind the shoulder. So the patient is upright, surgeon is standing and kind of off to the side behind them. There are some advantages to this position of doing the procedure in beach chair. It is an easier orientation for a surgeon to perform and also to learn, to prep, because as the camera is put in and the orientation of the visual is put up on the screen, the surgeon is already matching that position. So everything is anatomical up on the screen. There's no flipping around an image and trying to make it sideways, backwards, and turned around. It does also reduce the risk of overtensioning a repair. So when someone's procedure is performed at the side, it's easier for a surgeon, relatively speaking, easier, right? Surgery, I don't think ever is easy, but the tension is easier to gauge how much to put on because the arm is already in its position of max tension and relaxation. So the beach chair position is an advantage for tension management. In the case that the procedure needs to be transitioned to an open procedure for something such as a labral repair, it's also easier to do that without repositioning a patient. So why would anyone not choose the beach chair position? Well, there are some disadvantages, most related to cerebral perfusion. So because of the upright position and the fact that people's blood pressures are dropped so low with anesthesia, there can actually be inadequate cerebral perfusion, which obviously is a significant concern for brain function. It can also be more difficult to perform some labral repairs. The patient position that's used alternatively to beach chair would be the lateral decubitus position. This means that a patient is essentially in side lying with their operative arm being the top arm. So in the case that someone is being positioned in the lateral decubitus position, they're going to have their contralateral side flexed to about 90 degrees. This is going to be padded and supported on the table. And then their operative arm is actually going to be pulled away from the body in an abducted position between 20 and 45 degrees and put on traction again, similar to it was in the beach chair in order to open that subacromial space. So you'll see here is the arm being pulled into traction. The patient's head would be down here. That contralateral arm is padded and on the table down here. Now, in addition, I also have a mother who is an OR nurse during her earlier part of her career, and she often would talk to us about the importance of patient position and prep, because if someone wakes up from the surgery or is in post-op rehab and is complaining about musculoskeletal aches and pains that seem relatively unrelated to the procedure themselves, oftentimes the surgical prep could be a part of that. So if someone is laying on that arm in kind of a funny way, they may actually complain of pain in the contralateral side postoperatively, in addition to this one, or something with their head or neck based on how they were positioned. So having a lot of care taken in that preoperative time, prepping and draping the patient goes a long way for their overall outcome as well. So advantages of the lateral decubitus position is that cerebral perfusion is more protected. Seems like a relatively strong advantage in my perspective. And it does also provide better access to some parts of the labrum. From a disadvantage perspective, though, the orientation is much more challenging for a surgeon. So if you think about the patient being inside lying, the camera being there, the image being projected upright, and the surgeon standing upright, there's a lot of flipping of images to reorientate their procedure to kind of neutral. It can also be more difficult to assess the appropriate repair tension because of the degree of abduction of the shoulder. So when a tension is being applied and something is being stretched and tacked down, eventually that arm has to be put back down. So a surgeon has to be able to gauge how far and how much should I pull before anchoring it down in order to create an appropriate tension at neutral. So that would be more of a disadvantage of the lateral decubitus position. For the anesthesia, most surgeons will prefer having their patients under general, which means that they're getting an intravenous anesthetic. The patient will be intubated and rendered unconscious. Most of the time, this is chosen because they then will be unable to feel pain, and there's better control over the autonomic reflexes. Some of the advantages as well are better relaxation for the patient, and we mentioned pain control. The disadvantages of this are the decreases in the arterial pressures. So again, that perfusion tends to be more difficult when you're under general. And when you're in that beach chair position, then that puts the cerebral hyperperfusion on the radar. General anesthesia can also, though, be used in addition to a regional anesthesia. So what that looks like is a block. So oftentimes there's this interscalene block added as well, which is an indwelling nerve catheter. Why would you do both? Why would you do both general and that block? Well, it can decrease the need for intraoperative narcotics, and it can also decrease some of those deoxygenation events. So again, fairly large advantages. The disadvantage of that is the post-op neuro check is impaired. If you have a block in there, someone is not really going to be able to tell you what they feel after the surgical procedure in order to verify that no neurovascular structures were compromised. So a little bit more challenging initially, however, that is transient and eventually will allow, of course, for a neuro check. These are some of the instruments that are actually used in the procedure. So when we're talking about surgical instruments, we're going to break them up into 3 different categories. So this first category is the biggest one. It has the basic instruments. So the basic surgical instruments are things that, yes, are used in rotator cuff repairs, but they're also used in other arthroscopic procedures as well. So they're really less specific to this one, but they're all used in rotator cuff repairs. The second group of instruments is more of the specialty ones that are used for the steps of the cuff repair. And then the third category is disposables, things that get used one time and then pretty much are done. They either stay with the patient or they're disposed of. So those are our 3 categories, and we'll talk about each of these tools. So the first one is the scope, so the actual camera. In a rotator cuff repair, the most commonly used camera is called a 30-degree arthroscope. What that refers to is the viewing field. So 30-degree means that there is 30 degrees of visualization. This is essentially a surgeon's eyes within a procedure. So if they're doing something via a scope versus an open procedure, they can't directly visualize their tissue. So this camera is put in to allow the surgeon to, they call it, look around the corner and see the tissue that they're working on. And then this is the actual scope down here. This tool pictured below here is called the motorized shaver. So during a rotator cuff repair, we're going to be talking about how tissue is cleaned up. This cleanup is performed on soft tissue using a motorized shaver. So this being the kind of power end, this being the intervention end. This is a radiofrequency tissue ablation device, which is really essentially a cautery tool. So this is going to use heat to either clean up tissue or to reduce bleeding by cauterizing blood vessels. So the radiofrequency tissue ablation device is the one here that we'll talk about as the surgery is more in the exposure and cleanup phases. The burr tool looks a lot like the motorized shaver because the actual motor part is similar, but the attachment head is a little different. It's another cleanup tool, although the burr is used for bony tissue. So the motorized shaver was to clean up soft tissue. The burr is going to be used to resect more bone and to prepare that anchor site before the cuff gets tacked back down to the humerus. What you see in these pictures is actually the pump. So we have in a rotator cuff repair and other arthroscopic procedures as well, a fluid-filled joint capsule. So what they're actually doing is taking saline and pumping it into the shoulder to inflate it. So this is creating more workspace for them. It's also improving their visualization, and that continuously moving fluid is keeping everything looking clean and open and repairable for them. So these tools, this tower, the stack, as well as this, is going to be pumped through the tubing into the shoulder in a continuously moving cycle. We've got probes. So these little sticks here on the end, those are essentially a surgeon's way of palpating the tissue when they are not in an open procedure. So if they want to get in and they want to identify if something is loose or mobile or kind of tack on something, this may be their way to palpate during a scope. These little graspers are their way to pinch and hold any tissue that they're looking to evaluate mobility. And then switching sticks. So I think these look like glorified and probably very expensive chopsticks. But the purpose for this is actually to maintain access as they're cycling between tools. So these portal sites that the tools go into or the instruments go into are precise that they're trying to avoid neurovascular structures that could be compromised. So once that safe access is granted into the joint space, they're going to use these sticks in order to maintain the access. So they're essentially a placeholder so that the pathway is maintained in between tools so they can swap out instruments into the same space. This is a tissue punch. So when a repair site is ready to be tacked back down, it goes into their anchor point. Now, these tools are used to essentially make a guide hole or a pilot, just like you would drill into wood or a stud or any other type of a carpentry project where you would want to create a pilot hole before drilling in your screw. This is exactly what it's creating. So this device here at the end is what is going to create the hole, and then this hammer is going to essentially push in and create that pilot hole. These are the procedure-specific instruments, so we'll go into each of those a little bit more specifically as well. So these suture retrievers, they look a lot like the graspers. They're just used to help grab and manipulate the suture. We've got elevator. So if this looks like a wood chisel, it's because the picture is indeed a wood chisel. But I think of an elevator as being like a surgical spatula. So if you picture frying an egg on a frying pan that doesn't have nonstick surface or cooking oil, you put that egg on there and you go to flip it and it's going to be stuck. So the spatula can help to pry off that egg from the stuck spatula. That is what the elevator does for rotator cuff tissue that's been retracted and scarred down. That can help to release it from the tissue that it's been adhered to. Knot pushers are tools that help to deliver a knot to a repair site. So when a surgical knot is actually tied in a procedure, it's done outside of the shoulder joint most of the time. So then that knot that's been tied has to be sent back into the repair site with these sliding knots, and a knot pusher is going to deliver those. This is a guillotine knot cutter. It can also be referred to or swapped out with a surgical scissors that's going to trim the suture. So after it's tied and slid, it can be trimmed off as well. The device you see here, this is essentially the equivalent to a sewing needle for an arthroscopic rotator cuff repair. So it's called a penetrating direct suture passer, or also referred to commonly as a shuttle. So this is going to be responsible for feeding the suture through the repair site, pulling it back up. This is essentially doing the sewing in the actual repair. And then finally, our tools that are considered disposable. We'll talk through each of these a little bit. The first of them being the cannula. So the cannula is the tunnel that is used to pass the instruments in and out of the repair site. So when you see this threading at the bottom, that's actually screwed into the bone itself in order to maintain access. The free sutures, this is the actual string that's used to tie it together. You can see it kind of right here. This can either take the form of wire or tape. So when they say wire, it's not because it's suddenly metal. Wire and tape is referring to the suture shape. So a wire is going to be cylindrical, like a typical piece of yarn or thread, that shape would be. Tape, not meaning it's sticky, means that it's flat or broad, so more like a piece of ribbon. So it's kind of the difference between yarn versus ribbon when it comes to the shape. And this is going to be used, of course, to tie the repair back together. And then finally, the anchor. So the anchor is the piece here at the bottom of the tool. The rest of this green part is actually just used to insert the anchor. That's the piece that the whole repair is kind of tensioned back and anchored to, hence its name. The sutures are often already embedded into the anchor. So you can see that here, that suture is already part of the anchor instrumentation. So we keep talking about portal sites and the things, the instruments being passed through the portal sites. In a rotator cuff repair, it's common to have 4 main portal sites. The posterior one is typically where the scope is going to go. And then the lateral, anterolateral, and anterior portal sites are more commonly used for the instrumentation. If you're having a massive cuff repair done, or your patient is having a massive cuff repair done, they may need more portal sites to access different areas, but most common they'll have 4. And as you can see in this particular picture of one of the colleagues of my husband, one of his sports partners, they actually draw on the bony anatomical landmarks when looking to place the portal sites, so they can really be sure that they're palpating and mapping out their precise locations that they need to be working in. To touch base more specifically on the anatomical landmarks that are most advantageous to identify in portal site placement, it's the acromion, the AC joint, the lateral aspect of the clavicle, and the coracoid. Those are the ones that we saw drawn out on that previous slide. And then the real purpose of being so precise with these is to, again, avoid anatomical structures that could be at risk. These involve both nerve structures and vascular structures. So we're talking about the axillary nerve, musculocutaneous nerve, suprascapular nerve, kind of all of these ones here through the shoulder, as well as vascular structures such as the cephalic vein, which is this one right here over the anterior superior shoulder. By placing these strategically, they can minimize damage to any of those structures. So in this third and final section, we're going to start off by actually going through the steps of the rotator cuff repair. So our steps are listed here just in a chronological order. So we've got evaluation of the glenohumeral joint, we've got exposure of the rotator cuff, mobilization of the rotator cuff, placing the suture anchors, and then passing and tying the sutures. So we're going to go into each of those in a little bit more depth so we really know what they mean or how they're done before we get into some of the post-op considerations. So the first step being the evaluation of the glenohumeral joint. The reason that we want to talk about the evaluation of the joint as a whole is really to identify whether this is the most appropriate procedure. We also want to have a better idea if this is really the scope of the procedure that should be completed. So before going into performing an arthroscopic repair of the cuff, the surgeon is going to be looking at the ligament and capsule integrity, the health of the cartilage, as well as the bone status. So all of these things are going to be evaluated before they even turn their camera to the rotator cuff tear itself. In patients who have partial rotator cuff tears, there are some common intra-articular findings, especially if someone has had instability of the shoulder. So if we're talking about someone who has had a subluxation or a dislocation, these are times where you would be more anticipating some of the deviations and some of the issues that we see on this slide. So one of them being the Hill-Sachs defect, that would be on the head of the humerus from coming out of that glenohumeral joint, having the head of the humerus essentially bang into the rim of the glenoid fossa on its way back. You can also see labral lesions, of course, in that intra-articular space, or other features of this instability like a bony Bankart of the glenoid fossa as well from a dislocation. Once the health of the actual glenohumeral joint has been evaluated, then the focus can be turned to the rotator cuff itself. This is going to be done with exposure of the rotator cuff. So exposure of the cuff, this is going to be debridement. This is going to be potentially done with that radio frequency, so that cautery tool, just really looking to clean up and get down to the cuff itself. This is also oftentimes when a subacromial decompression is going to be done. So really taking that space under the acromion and giving more working room for the surgeon to perform the procedure and for the cuff itself to function. So in the case that they're trying to expose and debride, if they're looking at soft tissue, this would be a resection of structures such as the bursa in there. And if they're looking at bony tissue, this would be a resection of the acromion or performance of an acromioplasty. The subacromial decompression, though, however, isn't always included, and there are some significant benefits and drawbacks that get weighed against each other. So the benefits of doing that subacromial decompression are opening up the space under the acromion. This is often referred to in the op notes as an SAD. So if you see an SAD in a op report, that's probably referring to a subacromial decompression. It may be included because of the release of growth factors. It might be because that acromion is directly wearing on the rotator cuff and they're trying to remove some of that physical friction. It also improves the visualization for the surgeon during the procedure and gives them more physical space to work in. So those are reasons why subacromial decompression would be utilized. So kind of looking at that list, it seems pretty convincing. Why might it not be included? Part of that could be because when they compare outcomes functionally of patients who have had a cuff repair with an SAD and a cuff repair without it, they've actually found that there's really not a functional difference between the two groups. And in the group of an acromial decompression, there can be some weakening of the insertion of the deltoid and some anterior superior escape, or the humeral head somewhat drifting anterior superior in that glenoid cavity. So those would be reasons why a surgeon may opt not to actually include a subacromial decompression in a rotator cuff repair. After exposure, then the next step is to do the mobilization of the rotator cuff. This is when they're creating the necessary motion needed to pull the cuff back towards the bony insertion site. So if the cuff is torn, and we think about that crescent shape, that U shape, and the tendon and musculoskeletal or the musculotendinous component is retracted a little bit, that is going to have to be grabbed, pulled, and approximated back to the anchor point. So this is the step that is going to create the mobility for that cuff tissue to be pulled. So in that process, they're going to start by identifying the tear and determine the morphology. So in that case, they're going to determine, is it a crescent? Is it a U? Is it an L? Is this a massive tear? That's going to be the step one. Then they're going to perform the necessary releasers. So they're going to have the grasper, which is that little tool that pinches and holds and pulls. And then they're going to release the necessary tissue while putting traction on that to identify how loose they need to make it. Once they've got that completed, they'll give themselves some nice clean edges to work with. So the edge of the tear might be freshened up so it's not all frayed and difficult to tack back down. And then finally, if needed, they'll mobilize any retracted tissue with the elevator. So remember our egg on the pan and how it was stuck and they needed to release it by kind of trying to get it off without the cooking spray. That might be needed to do if the tissue has been retracted and scarred down. So any of that will be the next step to get that rotator cuff tissue nice and mobile so they can approximate it with the anchor site. Then the suture anchors will be put in once the tendon tissue is ready to be pulled. So that bony attachment site is where we're going to have the rotator cuff put back and stabilized to the humerus. Most of those anchors will come preloaded with the sutures. So once the anchor is placed, then the sutures will be ready for repair as well. The anchor material can vary. Sometimes it's metal, sometimes it's a bioabsorbable material, sometimes it's a non-absorbable plastic. There are even soft anchors that really are made just of suture. So which one of these is chosen might depend on the specific vendors that a surgeon works with, might be based on their training and which one they're most comfortable with or have seen the best results from. But any of these are options in the anchor material. Thinking about questions that our patients often ask us, if someone knows that they have a bioabsorbable anchor, the question that I would anticipate getting as a PT is, how long is it before those absorb, right? So this is the answer to that. Degradation of bioabsorbable anchors for cuffs typically take approximately 2 years. And what happens as they're absorbed is those anchors are replaced by calcified fibrous tissue. So next time one of those questions comes up in the clinic, hopefully you can have a little bit more of an educated answer to try and tell them. The passing and tying of sutures is what comes next. So you've got your glenohumeral joint evaluated and identified that it's not significantly arthritic or having any bony issues in it. We've had the rotator cuff exposed and kind of cleaned up to get down to the repair site itself. Then the rotator cuff has been mobilized and made sure that it has adequate mobility in order to get to an anchor site. The anchor itself has been prepped and placed so that there is a place to bring the cuff to attach it. And now it's time for the passing and tying of the sutures, which you could actually probably refer to of all of the steps as the repair itself. The technique depends on the shape of the tear. So how the actual sutures are placed is going to depend on that morphology. Crescent is the one that we'll talk about first. Regardless of that size, it's still the best kind of case scenario because that mobility is going to be really natural. It should be easier to pull it in, and it can be repaired down to the bone without having to pull very hard, not a lot of tension. U-shaped tears are going to have a slightly different technique because they're longer. You can see how it pulls down farther. They typically will do something called side-to-side convergence or margin convergence, where that large U-shaped tear is going to be closed this way first before it's pulled back up to the bone. So the result is actually to have a T-shaped repair because it's going to be closed side to side, and then it's going to be pulled back up towards the anchor site. An L-shaped tear is going to have to be repaired in the direction of greatest mobility. So they'll decide which way can they actually close it down first, and then based on that, they'll kind of follow the pattern into that and attach it back to the bone. And we're not going to touch base as much on the massive repair because that is a little bit more complicated and probably beyond the scope of us as rehab providers, but knowing that those more simple tear types are going to be repaired with those more predictable patterns. With a massive cuff tear, you might see a different variation of any of the above. Then the suture itself is actually going to be tied. So we're going to see the sutures retrieved using the suture retriever instrumentation. And then there's going to be a knot tied in the suture. This is then positioned down at the repair site using that knot pusher we talked about, which is going to slide it in, and then any excess is going to be trimmed off. So that is the process of actually tying down the suture itself. There are different variations in the surgical technique. We've talked about the use of subacromial decompression, may be used. Some surgeons may opt not to. We talked about how there's different anchor types and different suture styles and shapes. Any of those may be an option as well. And then there actually are some options for something called knotless rotator cuff sutures as well, where it's not tied in that traditional fashion. Any of those are variations that you may come across if you're reading operative notes about the rotator cuff repair. Another one is the repair construct, and I think this is the one that probably gets talked about a little bit more often and may get debated among surgical specialists. So I thought this would be a good one for us to learn more about because it's typically annotated in the note which the surgeon chose. So the first one we'll talk about is the single row. The single row is the one over here, right across from it, where you see that the tendon is essentially pulled down to the bone, and it's put with the anchors just right there along the proximal, or I guess that would be kind of the lateral insertion site. This is a little bit faster. It requires a little bit less complicated work. It does require less tendon length because you don't have to pull it as far. So it's better suited for small tears. Then there is a double row, which is the one shown right after it here. This one is where we're essentially seeing a second row of anchors placed for an additional set of sutures to be placed. This one has been shown in the research to actually be biomechanically superior, meaning that when they pull on a tendon and they compare how hard can they pull before it re-tears, a double row construct can withstand higher loads prior to failure than a single row. It does have improved footprint restoration, and when they compare re-tear rates, there are lower re-tear rates compared to a single row. So at face value, you'd say, well, it sounds like a double row is superior to a single row. However, it actually has been shown that re-tear rates may not functionally matter all that much in post-op rotator cuff repair outcomes. It has been shown that many times, even patients who have retorn their cuff still have functional outcomes that show good prognosis and success. So, although patients with a double row may technically have lower re-tear rates, their functional outcomes actually are very similar to those with single row. The final option is this transosseous equivalent, which is a suture bridge, which you can see here. It almost looks like a crisscross. This provides a broader surface area because that suture is actually bridged all the way across. The biggest concern with this one is that it may have some impact on vascularity because it's creating more compression. So overall, those are the three different primary constructs that you'll read about in rotator cuff technique. There is also a variation called an interval slide, not to be confused with the playground slide. I think for those of you joining us from Florida, the idea of a metal slide, you'd probably stick to it with all of the heat. But a rotator cuff interval slide is when they're releasing the interval from a retracted supraspinatus tendon. So if you have a large tear, a chronic tear that's had more time to retract and scar down, an interval slide might be needed in order to release it from the rotator interval. Another variation involves the management of the biceps. So the biceps can oftentimes have partial or full tearing that go along with a cuff tear. And in that case, it can be managed oftentimes either with a tenodesis or a tenotomy. The main difference between these two is that when the long head of the biceps is released from its proximal insertion, with a tenodesis, it's allowed to be actually reattached to the humerus, compared to a tenotomy where after the release, it just scars down in place. Functionally, there has actually been shown good outcomes with both process. So although surgeons may have a preference one way or the other, the tenodesis and the tenotomy do typically have fairly similar outcomes in improvement with both pain and function. I think I typically see patients having a bigger preference one way or the other because it's hard for a lot of them to comprehend the fact that with a tenotomy, not reattaching their biceps, that they would still have good functional outcome, even though the research does support that. Most of the time, patients postoperatively from a rotator cuff repair will have their arm put in a sling or in a mobilizer, like an abduction sling. By having it abducted away from the body at that slight 30-degree angle, it does improve vascularization of the cuff, so there's better blood flow through that area of repair. It can also decrease the tension. We talk a lot in the second section of the course about the positioning and how the amount of tension put on that repair at an abducted versus a neutral position matters and how it pulls on the structures. By having a sling that's slightly abducted away from the body, that tension can be reduced during those initial phases of healing. Typically, a sling is going to be used about 6 weeks. It's not uncommon in a massive cuff repair to be used for slightly longer than that. Pain control is a big factor post-op rotator cuff repair. If you're in a group that typically gets referrals for post-op cuff repairs in the first 2 weeks or so from surgery, you're probably very familiar with the amount of pain and discomfort that patients typically have in those first couple weeks. And in the past, opioids were the primary analgesic strategy used for patients post-op. On average, surgeons were typically prescribing between 60 and 80 pills. This was often refilled for them as well. The studies had looked into what the risks of using opioids in this population were, and what they were seeing is that between 8 and 15% of all cuff repair patients were still using opioids even 6 months after surgery. So at that point, we're really looking at ways that we can try and reduce the opioid utilization. Of course, it's not hard to justify why you'd want to reduce them, because the side effect profile is quite long and can be debilitating. We've got constipation, nausea, vomiting, respiratory distress, and somnolence, sleep disturbance, urinary retention, and of course, dependence and addiction, which tend to be the ones that kind of put this in a totally different category than some of our other analgesic medications. So there are current recommendations that have been published to try and help more of a multimodal pain control for cuff surgery. And that's what's broken down here. I know the font's a little small, but I wanted to include all of it because I thought this was a really valuable pathway to really point out. So the 3 different phases of pain control are pre-op, surgery, and post-op. So as you can see, pain management doesn't wait until a patient wakes up in order to get started. Pre-op, the strategies that will get utilized involve education on both surgical expectations and pain management strategies. Risk factor assessment, I think surgeons oftentimes are trying to identify in their offices preoperatively what type of management their patients might need and how well they might deal with a post-op pain period. And then actually preoperatively starting some versions of medications, which might be over the counters like acetaminophen, but can also be things like nerve-based medications of gabapentin. Actually, in the surgical procedure, interscalene blocks, like we talked about as an anesthesia add-on, can be used with medication like dexamethasone in order to help patients have the less reliance on narcotics. And then finally, once we get to that post-op period, there might be some utilization of medication like oxycodone. However, partnering that with acetaminophen, gabapentin, or ibuprofen may also help to reduce some of the reliance and some of the duration of opioid medications. I wanted to circle back all the way to phase 1 of today's course to relate that histological healing and the post-op management. So I mentioned that I don't love getting into the weeds of histology just for the sake of it, but if it comes into functionally impacting what we do with our patients, then it's worth talking about. So this is how it ties into function. So when we're going through this process over time, the first box we see is surgical tendon to bone fixation. So this is the actual repair. So step 1, repair the surgery, right? Then once we do that, what we see is that the inflammatory cells like platelets and fibroblasts, they all start to flood to the repair site. So we're getting the delivery of the soldiers that are going to battle for our repair. From there, we get proliferation and we get that matrix deposition of our repaired scar tissue of collagen. Now, this is the piece where we were talking about collagen type. You can see that at this point in the process, we have type 3 collagen. So type 3 collagen was not our mature normal collagen type for tendinous tissue. So at this point, we would consider it to be an immature scar. As we go into the next phase, the scar will begin to remodel and organize. It'll start to look more like actual rotator cuff tissue. And then once we get onto this next box, that's when our collagen is really replaced from a type 3 to a type 1, and we start to get mature. This is where our tendon is starting to really look more like a healed product. And then when we get into the final box, this tensile strength that we need to really perform, that's going to happen in a timeline about 12 or more weeks after surgery. So we're looking at really a multi-month process of healing taking place. When we're talking with our patients, there are going to be some people who are feeling good, who are looking good, whose motion is right on track, who want to move forward, who want to go to the next step. So when we're talking about moving on to the next step, we have to think about, is the patient ready from a tendon to bone healing perspective? Because we know that the rate limiting function in recovery is the ability of the rotator cuff to heal down to the greater tuberosity. And this takes between 8 to 12 weeks. So no matter how great someone is doing in those first 2 months, 3 months, we need to make sure that we kind of pump the brakes with them until that has been shown to be healed down. Then we can start to push things a little bit more into active motion. In the physical therapy postoperative, there are two different kind of trajectories that some might go into. There's early rehab and there's a late rehab. So in early rehab, we're talking about people who are getting referred to start PT within 1 to 2 weeks following their surgery. The late category is people who are waiting 6 weeks to get into PT. These two timelines have been compared against each other when they're looking at long-term outcomes for patients, and there is really no evidence to show that one is better than the other. So really, it'll probably come down to surgeon preference and protocol, but either way, these patients tend to have similar functional scores, pain, range of motion, strength, and retear rate. The other main difference in the approach to PT is the method of mobilization. So in early rehab, it's very common that the shoulder is taken through passive range of motion. The scarring is intended to try and retain mobility so that the shoulder keeps up its status as being a mobile joint. In that case, it can either be done manually, passive range of motion with a rehab provider, or it can be done passively with a CPM machine or one of those fancy chairs, as our patients often call them, where the arm is strapped in and taken through a range of motion. Similarly to the timing of rehab, when they compare practitioner provided manual therapy and that passive range compared to a CPM chair, the outcomes of both patient seem to be relatively equivalent. So there is no preferred method one way or the other when it comes to total outcomes with patients. So then let's talk a little bit about the physical therapy interventions, right? So we know we've gotten the patient through the surgical procedure. We're working our way through that healing process. What is it that we should be doing as rehab providers at each one of those phases? So let's start with phase one. Phase one is when we were in that inflammatory and repair phase. So that's when we were really getting all of the cells flooding the repair site, starting to lay down the initial phases of collagen. So our job as rehab providers in phase one is merely to maintain the motion we have and to allow the inflammatory process to do its job. It's essentially a do no harm phase. We want to try and maybe optimize the things around the shoulder that are collateral damage from the surgery and keep the shoulder kind of happy and just allowing the inflammatory process to do its thing. So at the actual shoulder, this typically looks like purely passive range of motion, and that's it. Might be at 1 or 2 weeks post-op, might be not until 6, just depending on the specific protocol. These passive range of motions are typically done in supine. They're typically done with a patient maybe a little bit elevated if they're having difficulty with laying flat on their back. Oftentimes, some light oscillation, long axis distraction might improve patient pain tolerance as you're going through some of that range as well. Around the shoulder joint, the elbow, wrist, hand, and cervical spine typically don't have the same restrictions for active range of motion. So this is a good time to be taking advantage of the time out of the sling to be doing biceps range of motion, some wrist movements, as well as kind of grip and cervical turns as well, rotation through there. It's also a good time to talk about posture with patients. In the sling phase, a lot of patients are going to be kind of hiking up to support the sling with their contralateral side. A lot of people will get upper trap tightness or levator scap tightness because of that sling wear. So using this time to really talk about postural things like retracting and depressing that shoulder, keeping them relaxed and down. Using it to maybe do some upper trap or levator scap stretches could be a good phase for that, and just that scapular setting, of course, throughout the day, even if they're not wearing their sling. Then when we enter into phase 2, this is when the scarring and the tissue healing starts to go into remodeling. So now that everything has been laid down, we need to start to make it look more like a rotator cuff. So things in our rehab that are going to do that are active assisted range of motion. So we're going to start to take the shoulder through motion in a way that the tendon starts to participate a little bit. Active assisted range of motion in this phase is typically going to be that dowel assisted. So where someone's going to take like a bar and pull up overhead. Sometimes people will take hand to wrist and do active assisted this way. I often see a cane used in the clinic or a golf club when we're doing our external rotation active assisted. That's the one probably that we need to be the most mindful of when we're instructing our patients. So many people will really cheat into that elbow extension as they're going to rotate into external rotation because they feel like they're doing so great. They'll be so proud of themselves. And then when you pull them back into elbow flexion and go to externally rotate, all of their motion disappears. So that's probably the active assisted one that we need to spend the most time on form and mechanics with. Over time, this will start to transition in phase 2 into active range of motion. And active range of motion can happen across planes. So active range of motion can be gravity assisted, could be gravity eliminated, or it could be anti-gravity. So for an example, an active range of motion that's gravity assisted might be a prone, let's think, like prone shoulder flexion going from side of the table down towards the floor. So that type of shoulder flexion would be gravity assisted. If you're looking for gravity eliminated, if somebody is in side lying and they're moving their hand across the horizontal plane, that's going to be gravity eliminated active range of motion elevation, which then can be transitioned into gravity, anti-gravity in an upright position, sitting or standing. So in this remodeling phase, you could be going through all versions of that motion. Scapular proprioception is most likely to be in the phase 2, looking like scapular clocks. So thinking about 12 o'clock, 6 o'clock, 9 o'clock, and 3 o'clock. Having the shoulder go through those different positions and being aware of where it is in space. And then also getting into our submax isometrics. So now we're trying to condition the tendon to start to accept load again. I think it's really important in the submax isometric phase that we're talking to our patients about the goals and expectations for submaximal isometrics. A lot of times when people get to this phase, they're excited to get into strengthening and they want to push the wall down, right? And people will say, this hurts. Well, when we're talking sub-max isometrics, it's great messaging to our patients to say, we're not using this to build bulk. This is not what's going to make us stronger. This is really more a perspective of waking up the tendon. We're trying to increase the circulation. We're trying to remind it of its job. That can often help our patients to achieve that maybe 50% effort that we're looking for, instead of having people really using this as a maximal isometric and causing pain. A lot of times when I'm trying to gauge how hard a patient is pushing, I'll actually stick my hand between their fist and the wall, and I'll tell them, show me how hard you're pushing. And I can gauge pretty quickly whether someone is really overexerting into that, because if they're going to push me pretty hard, guaranteed when my hand is there, they're probably holding back a little bit compared to when I'm not. So again, remodeling phase, trying to really show the tendon its role, but not necessarily challenging it to this extreme at this point. We're just trying to really wake it up and show it its job. Phase 3 then is where we start to strengthen it. We start to challenge the capacity of the muscle. This is going to be now an isotonic strengthening. So we're going through that active range of motion, typically with a free weight. Bands can be used, of course, especially when we're in those rotational ones, but we need to think about band versus free weight and how the length tension relationship is going to impact our mechanics and our exertion. So with a free weight, you're going to have a fairly consistent amount of load through the entire range. Now, yes, the lever arm is going to slightly change, which will make the relative workload change a little bit throughout the range of motion. However, when we compare that change to that of a resistance band is going to pull, increase in force all the way to the end range of motion, which is when the muscle's length tension relationship is going to be the least advantageous for strength training. So sometimes we'll see a lot more compensation patterns pop up when we see someone using a resistance band because of that mismatch. So when it permits, I typically prefer to use the free weights. Cable column machines have more of a consistent range and pull and load than bands do. But of course, for ease of compliance at home, patients may need to use bands, and that's always fine as well. We'll also be doing scapular strengthening, right? We keep talking about the stable base for the cuff to work off of. That's when the scapular strengthening really shines. So we want to be thinking about exercises like our classic I's, T's, and Y's. So we're doing our middle trap, lower trap, upper trap. We're getting all of that scapular strengthening. We're trying to make sure, though, that as we go through these strengthening exercises, that we don't get scapular elevation. When our cuff is weak and we don't have a lot of elevation strength, a lot of times the body's compensation pattern will be to shrug in order to create extra elevation. So if a patient is really demonstrating those patterns in this rotator cuff strengthening phase, we want to try and tease that out and try and reduce the weight that we're using in order to really achieve good mechanics and avoid the scapular shrug, so we don't get impingement. Right? We don't want to impinge on this newly repaired rotator cuff. So that would be our phase 3 of strengthening. Then phase 4, once we have a strong and reestablished rotator cuff, now we need to get them ready for whatever activity it is that they're going back to. So if someone is going back to a desk job with relatively low demands, really phase 3 might be all that they end up going through. But if someone is going back to playing baseball or playing pickleball, or maybe going through maybe a higher level occupational demand like firefighting or construction type of work, they're going to need to go into this phase 4, which is advanced rotator cuff strengthening and looking like our task specific rehab. So let's give an example of a pitcher, someone in baseball. You're going to have to go through a return to throwing program where you're gradually going to increase the distance that someone can throw at, gradually increase the throw count, so the pitch count, so how much volume they can tolerate, trying to get them back into those mechanics in a graduated way. Some other sports-specific options, let's say we have someone who is a tennis player and I'm working on proprioception and I have one of the proprioception blades. If I'm going through the range of motion, I shouldn't be working on that proprioception just through these planes. I need to be going through the full range of their serve, maybe through the full range of their swing. We need to be looking at that really sport specific or activity specific pattern. So similar things for occupational. Let's say I'm working with a firefighter who has to do overhead ceiling pulls. So if I'm taking one of my pulling poles, which are going up to the ceiling to rip down a ceiling looking for hot spots, I know that I'm going to have a rotator cuff that's going to be elevating, striking, and pulling down. So I should be doing some of my strength overhead in that same type of pattern. So again, sport-specific activities, activity-specific training, so that we're able to replicate it. If I do all of my strengthening down here, below 90 degrees, and I put someone back in an occupational or sports task that's overhead, I would not expect them to succeed. It would essentially be like they've never trained. So we need to make sure that we're doing it both. Talking about endurance, right? We brought up fiber type early on. Yes, these muscles need to have strength, but they also need to have endurance. So looking at how we can bring together both the endurance perspective and the strength perspective, we need to have some high rep tolerance in each of our sets. And then finally on this list is plyos, right? So there is one thing to going slow and control, slow and control, slow and control. But a lot of these tasks that our shoulder is demanded to do involve quick and plyometric type of force. So if we're going to be sending someone back to something with speed, a catch, a throw, anything like that, we probably need to involve plyometrics. And the plyometric programs for upper extremity are not often as talked about as those for the lower extremity. Thinking about post-op ACL or a post-op meniscal repair, plyometric protocols are everywhere. You can find plenty of literature, plenty of examples of great plyometric programs. It's a lot harder to find them for the shoulder. So if you're looking for some plyometric exercise ideas, some of them that you can use involve like ball on the wall. So if you take a small medicine ball, like I would say a half a pound to a pound at most, you can do throws or even tennis ball catches and throws against the wall up at 90-90. You can also use a rebounder or a trampoline kind of tipped up towards somebody, and they can throw double arm and catch back, or they can throw and catch single arm against the rebounder as well. Sometimes this will be done in more of a push-up type position where there is a box next to the patient and they will walk up on the box with their hands and then down, or two boxes. So up, up, down, down in more of a plyometric phase, or even just a side-to-side tap in that weight-bearing plyometric. So there are ways that you can work on this, kind of progressing into things like throwing or faster pace. But just making sure that we're really preparing our patients for truly the activity they're going back to. This is the piece on alternative surgical management. So that kind of took us through the full process of what someone might expect if they're going from pre-op to operative management to post-op. But what about those people who have a rotator cuff tear, who aren't good candidates for conservative management, but aren't good candidates for an arthroscopic repair? What else might they have done instead? So that's what's on this list here. So the first one is a subacromial decompression and a rotator cuff debridement alone, meaning that it's not actually repaired. It's cleaned up, it's opened out, but it's not actually repaired back down. So who would have that? That might be for a patient who has a low-grade partial articular-sided rotator cuff tear. So again, we talked about bursal side being the top, articular side being closer to the humerus. If someone has that articular-sided cuff tear that's a partial tear, they might just clean it up and not actually repair it. There is also a procedure called a tendon transfer. So this might be used in some people who have massive cuff tears that aren't really repairable. Instead of repairing something down, they'll actually take another muscle in the proximity and they'll use that and move it to the place that the rotator cuff would have needed to be. So they can use the pec tendon, they can use lat tendons, they can use a variety of different muscles from that area and move them in order to replicate the function of the cuff. There's also something called a superior capsular reconstruction. This is again for massive irreparable cuff tears, but they need to have an intact subscap. In that case, what they're going to be doing is actually using an allograft or an autograft and transplanting that essentially to the superior capsule to reconstruct it. And then finally, that reverse total shoulder. This is going to be used for some people who have massive tears if they're over the age of 65 and have that glenohumeral arthritis, but their deltoid is intact. So with these reverse total shoulder procedures, they're essentially going to eliminate the need for a cuff by having the humeral component and the glenoid component change their arthrokinematics. If we're talking a little bit about the outcomes, what can people expect after rotator cuff repairs? There are times complications. I would say some of the most common ones are stiffness. So I'm sure if you've rehabbed enough post-op rotator cuff repairs, there are some of those patients who just struggle to get back their full motion. Part of that can be scar tissue, arthrofibrosis, but sometimes it could be the actual tension put on the cuff as it's being repaired down. Some people could have persistent pain. This could be because maybe the cuff wasn't causing the pain in the first place. Just because they had a tear doesn't mean it was the cause of their pain. It could also be from more of a pain neuro diagnosis like CRPS or chronic regional pain syndrome. Clearly, a severe complication would be that cerebral hyperperfusion from the positioning and anesthesia, which could be resulting in a stroke or blindness. Again, fortunately rare. And then nerve injuries due to pressure or traction actually in the positioning of the surgery. Luckily, these are usually self-limiting. So if someone does have one of these nerve injuries, they usually improve over time. And then very rare in an arthroscopic rotator cuff repair, but still worth putting on the list, are infections and blood clots. The outcomes, when we look at evaluating them, our main metrics are impairments. So how is their range of motion? How is their strength post-op? How are they functioning based on their own report of questionnaires? And similarly, their quality of life. How is their pain? Are they overall happy? Are they satisfied? And then if they actually evaluate with imaging or another follow-up surgical procedure, how is the tendon looking? Is it actually healed or has there been a re-tear? When they look at some of these metrics, they show a huge variety of outcome amongst the research. Re-tear rates as low as 13%, but as high as 95%. So essentially what we can take away from this data is that a lot of people will re-tear after their original rotator cuff repair. The most common mechanism for this that they've identified during revision surgery is a failed fixation at the suture tendon interface. And most of the time, this is happening in the first 6 months. What's really interesting, though, and I think something that we don't see with all kinds of procedures, is the fact that when someone does re-tear, their function doesn't necessarily get impaired along with it. So there are some parts post-op rotator cuff repair that even if you re-tear, your outcomes are good. So that's kind of what we're going to talk about here. In the case of a re-tear, range of motion between those who have retained good congruency and those who have torn is actually maintained. Range of motion doesn't seem to fall back in the case of re-tear. However, strength does show a deficit. So if someone re-tears post-op rotator cuff repair, they are more likely to have forward flexion and external rotation strength deficits around 40%. What about, though, the functional outcomes from the patients or our patient-reported outcomes? If someone re-tears, they've actually been shown to maintain their functional gains. So this is the point where we come to ask and debate, does a re-tear rate really matter if our functional and patient-reported outcomes are still better after surgery? Either way, if we're kind of looking at who does well after surgery, there are a few different factors that can predict that. In the demographic category, the people we see do better are those who are younger and those who are male. Um, these little pilots are giving you a double thumbs up, right? Because that's what you want. You want it to be good prognostics. You'd be surprised how many pictures I could find of little kids giving thumbs up. So I'm going to run them through all of these next slides. They make me smile every time. Clinical factors of positive prognosticators would be higher bone mineral density, not being diabetic, having more activity in sports, pre-op if you had better range of motion, and lower BMI. Double thumbs up, you're likely to do better. Factors related to cuff integrity, so essentially less severe, better prognosis. So that comes with less retraction, less fatty infiltration, not having as many tendons. He's a little bit more reserved, but still double thumbs up for that as well. And then finally, factors related to the actual surgical procedure. Not having a biceps or an AC joint procedure does lead to a higher prognosticator for positive outcomes. So double thumbs up. And that brings us to the conclusion of our presentation today, where we're really just reflecting on the fact that arthroscopic rotator cuff tear is a commonly utilized procedure in the surgical management of cuff tears. So by better understanding this, we can evaluate and go through the rehab in a way that's more informed and provide better quality of care to our patients. So that's our overall goal today with understanding the surgical process better. What is the difference between a reverse and anatomic total shoulder arthroplasty? So this is a great question because it really interplays with the rotator cuff tear. So a reverse total shoulder is going to be one where they actually have the concave and the convex components of the glenohumeral joint switched. So instead of the glenoid being concave, it's actually a convex fossa, so it's not really a fossa at all. And then the head of the humerus becomes concave. So we actually just reverse the way that the arthrokinematics work. The reason that someone might have that, it's really reserved for people who don't have a functioning rotator cuff, because an anatomic total shoulder is going to have the mechanics actually in the original orientation. So the glenoid fossa is going to be replaced with the concave surface. The head of the humerus is going to be replaced with, again, the convex surface. So those anatomical procedures actually have better outcomes for patients. They're typically used in people who are younger, people who have more intact soft tissue around that. And that's the preferential procedure whenever possible, because the outcomes really are optimal. The function for the patient is better. The actual components are typically preferred. We're talking about that reverse total shoulder, in that case, we're going to have those components switched, and someone is only really going to be opting for that procedure when they're not eligible for the anatomic. So although there are two different approaches for that with the components, we're seeing it really used in two different patient populations. So one being younger and healthier, one being older and having a little bit less rotator cuff integrity or a little bit less support from the rotator cuff, and the actual components and pieces and the procedure and how it's performed is different. So if given the choice, it sounds like it's probably more preferential to go towards the anatomic. It does require, though, that the muscles of the cuff can actually help with that roll and glide system. So it does require that the rotator cuff muscles can help to depress and stabilize the shoulder as we're going to lift it up overhead. Without the cuff to do that, we would have the difficulty of that superior glide of the humerus and run into the approximation in that coracoacromial space. So that's why we really don't want to be putting in that system unless we have the proper support and stability and arthrokinematic facilitators of the cuff. How would the rehab program differ for a partial rotator cuff tear versus impingement? When we're talking about rotator cuff tears versus impingement, first, we just have to reference back to that slide we talked about earlier today, where we acknowledge that it's somewhat of a continuum, right? So impingement may actually have some degree of partial tearing in it, and partial tears may in some ways come from impingement type mechanics. So I think that's the first piece just to acknowledge. And then moving forward, we can talk about how we would emphasize the rehab a little bit differently. So with a partial rotator cuff tear, first, let's just talk about what the goal would be. So we know that if we have a partial cuff torn, that also tells us that we have part of the cuff intact. So the part of the cuff that is intact is what we want to try and optimize. We're essentially trying to make that intact piece of the cuff function as well as the original cuff really would have. So when I'm thinking of partial cuff tear rehab, I'm thinking of ways that I can strengthen the cuff in its entirety in order to make it more functional and to pick up the slack maybe for those torn fibers. So if I'm working on the supraspinatus, that's going through a very classic elevation type of strengthening pattern, doing that across different positions with different types of weight. If I'm looking at the infraspinatus, I'm going to be doing my rotational exercises at the side, again, from different positions through different conditions. So things like speed and control. And then teres, of course, up here, doing that 90-90 type of position, again, at varying degrees of speed and different types of resistance. And then subscap in our internal rotation type of position. When we're looking at impingement, then, we're talking about our ultimate goal of trying to improve the mechanics, right? So our underlying issue in impingement is that we're getting some of that faulty roll and glide where we're having an excess superior drift and we're closing down that space. So since our goal with impingement then is trying to optimize mechanics, yes, I'm going to still want to strengthen the cuff. However, I'm going to put a lot more emphasis on my scapular strengthening. So in my impingement cases, I'm really going to look at recruitment of my middle and my lower scapular muscles so that I can avoid this constant shrug elevation pattern and get a little bit more of that retracted and open elevation pattern. So a lot of times what we'll see when we have people do scapular strengthening and have them go through rows or any kind of posterior muscle work, we see that upper recruitment pattern. So I'll spend a lot of time really emphasizing and helping a patient to find their middle and lower trap muscles so that they can use them to try and set and stabilize the shoulder blade. So oftentimes that's done, well, I'll usually start upwards in a row with a band and just see what happens. And then if I cue them and give them usually a tactile cue where I've got my fingers between their shoulder blades and poking around, and I'll let them know, what if you try and take those little borders of the scapula on the bottom and you try and pull them down and back? If they can do that, great. We'll focus on that moving forward. If they struggle with that, then I may actually have to put them in a different position. We might try it laying prone, and then I'll have them do the same thing. Try and pull back, try and cue them to pull it down and back at the same time. If we're still not able to retrain the mechanics in that position, then I'll often switch to sideline. And in sideline, I can physically manhandle their scapula and show them the pattern I'm looking for, which is going to be that retraction, depression combination to try and teach them where to go. I'll go from passive to active assistive, and then hopefully at the end it can be like, look, mom, no hands. They're able to pull those rotator cuff or there's scapular muscles back to open up the space for the cuff. So again, our cuff tears, our impingement, we need components of both, right? We need the cuff to be strong to depress the humeral head. We also need the scapular muscles to stabilize in both, but we're just going to have a little bit different emphasis in each of them. Is there a standard protocol for PT following a PRP injection? So just a reminder for those of us who might not be as familiar with it, that PRP stands for platelet-rich plasma injections. So those are the ones where a patient's blood is being withdrawn, spun down, and then the red blood cells and the platelets are being injected back into the site. So what we're actually seeing at this point is that there isn't much of a standard when it comes to PT following PRP. It's a little bit still more of that Wild West program where you might have one physician who handles it and recommends PT is following a specific protocol, and another physician might actually follow something that's incredibly different. I can give you some examples of ones that I've seen or that the physicians that I have read protocols from align with more. But typically in those, what you're seeing is those initial 2 weeks following the procedure that a patient is recommended to be in a isometric exercise only type of phase. So they're likely not doing a lot of tendon rebuilding. They're not doing a lot of heavy loading. For those first 2 weeks, it's isometrics for blood flow, but not really putting the tendon under a lot of extra load. So again, first 2 weeks, maybe more of an isometric phase. Then the next phase following that is typically eccentrics focused. So they'll go from an isometric phase to an eccentric phase where that tendon is going to be put under that very specific remodeling load that we often see in tendinopathy. And that may last until the 6-week mark or somewhere around there. So maybe a 4-week period focusing more on eccentrics. And then after the 6-week mark, it's common for them to have a transition from an eccentric to more of a functional and integrated exercise pattern and that heavier load under more open-ended conditions. So during that full 6-week period of time, and they're working on the isometrics and the eccentrics, it is common also for them to be told not to utilize any anti-inflammatories. So from a medication perspective, they're trying not to introduce any anti-inflammatories to allow the inflammatory process and cascade really to do its job and go through. So again, at this point, there'll be a ton of variation in what you see if you have a patient after PRP from a few different physicians. But the ones that I've seen most commonly are a period of isometrics followed by eccentrics before return to functional activity. How would a patient reintroduce throwing or pitching after rotator cuff repair? It's great that you ask this because in our return to sport world in orthopedics and rehab, there is so much emphasis on return to sport for our lower body surgeries. If we have an ACL or a meniscus or an FAI and we have people going back to sport after that, there are batteries of protocols to take patients through in order to gradually return them to running, gradually return them to sports. But when we get to the upper extremity, Interestingly enough, it's a very different world. We don't see as many commonly published protocols on returning people to throwing. So I think the best way to reference this is to actually look at our baseball players. Baseball players have some of the most objective return to throwing and pitching programs after rotator cuff repair. And these are actually treated a lot like return to running programs. So what you'll see is variation in distance. So from, running distance, we're often talking about miles and time. When it comes to distance in pitching, we're talking about whether they're throwing all the way from the mound or whether they're throwing from a shortened distance. So doing some throwing reintroduction might happen from a graduated distance over time. There will also be some variations in frequency. So you might have a longer rest period in between where someone isn't allowed to throw every day at the beginning. They might be throwing a couple times a week, alternating with other rehab programs, and then gradually increasing that frequency for how many days a week that they're allowed to throw. You'll also see volume graduations. So they may start with a certain number of pitches allowed or throws allowed, and that'll gradually be increased. So you might start with 15 or 20 throws, working their way up to 50 throws, getting that volume gradually increased. So we've had an increase in distance, an increase in frequency, an increase in volume. And then we also have an increase in effort. So the effort will go in some hand-to-hand way with the distance, right? You have to throw a lot harder to make it all the way from the mound than you would have to throw if you were halfway to the mound. However, within that, you can still offer a variation in how intense you're throwing. Even from the mound, you can throw 75% of your effort versus 100. So working that up gradually as well. And in this reintroduction progression, you'll also be looking for pain, soreness, edema as part of the tolerance barometer as you're going through. So if you have an introduction to throwing program with some of these larger rest breaks, shorter distances, less intensity, less volume, you give it a day and you see how the shoulder feels the day afterwards. If it goes well, then that gives you more of a green light to continue to progress. And that process can be increased over the course of a couple weeks. It might take a couple months, depending on how it's going and what level of throwing and pitching you're looking to work your patient up to. What are common compensation patterns seen during the strengthening phase of a post-op rotator cuff program? Compensations are key, right? Our exercise quality matters just as much as any of the other factors like quantity. And as we all know, as rehab professionals, the body is amazing at finding the path of least resistance. So in the case of post-op rotator cuff, we definitely have muscles that are going to be looking for cheats, right? For cheat codes to get out of having to work hard. So if we can identify those and hold our patients to them, then we can help them to actually create functional movement patterns again and try and strengthen as we go through. So I think the ones that come to mind first, or the ones that we see most often, are for the external rotators. So when we've got patients working through this external rotation, often with a band and standing, we'll see a lot of substitutions with elbow extension. So as people are trying to create the illusion of external rotation, they'll just extend the elbow, feeling like they're getting that end range extension or external rotation, and it's truly just extension. So that's one where we really want to call them out. If someone after their rotator cuff repair is working on strengthening their external rotation and feel like they could do it all day, it's probably a good sign that they're doing some sort of compensation pattern in there, because it should be hard. The other one that I see a lot of is the scapular retraction. So if someone is going to externally rotate, it's actually possible to also create that illusion of motion by having external rotation combined with retraction of the shoulder blade. So they're actually pulling back to create that stationary arm looking like it's externally rotated. So those are probably the two that I see the most common there. So by having the shoulder anchored, standing behind someone, and actually having my hands near their scapula, I can feel for stability there. And then I'll often give people a cue to have their hand end up higher than their elbow when they're done. Although we really just need it level, by having them think about it be higher, we don't allow them to extend. When it comes to the supraspinatus, we see a couple different ones for that, of course. The most common is the upper trap shrug. So someone is going to create that elevation pattern. We see this happen to try and give that illusion of the arm raising up higher. Well, I guess it actually does raise up higher, but we're getting that illusion of it coming from the cuff. So if someone is telling you that at the end of their exercise they're tired, and you ask them where, if they say anywhere up here, that tells you that we're probably getting a pretty significant compensation from the upper trap. And you can often see that as the provider. You can actually watch those muscles kick in and be tight and be active. So that's a good one. Or to ask them how they felt the next time you see them afterwards. Were they sore? And if they say yes, and it comes into this upper trap region, then you know that that's probably something you need to educate them on. The other one we see with arm elevation is the lateral trunk lean. So a lot of times people have no concept of the fact that as they raise their arm up, they're actually trying to lift their whole body to the side in order to make that arm raise. So I think one of the things that we can do is not just identify these, but teach the patients to identify them themselves. If a patient can feel their own compensation and identify them, then they're going to get so much more out of their rehab program in between visits, because they're not going to be just reinforcing these compensation patterns at home if they are compliant with their program. How would the PT intervention change if a patient has calcific tendonitis versus a partial rotator cuff tear? I love talking about the differential diagnosis and how that plays into how you would rehab something, because I think it's part of the reason why a lot of patients might fail conservative management when they really did have a chance to succeed. So when we're talking about the case of calcific tendonitis, we're talking about that calcification that builds up within the musculotendinous unit of the rotator cuff in this case. So when a patient goes to activate that muscle, we are seeing a irritation and acute pain that comes from the presence of that calcific body. That's different than our partial tear, which we're seeing pain of for different reasons, which we're really just focusing on trying to get that strength up. With our calcific tendonitis cases, then we're trying to limit how much acute inflammation and irritation we have. So I would often limit my calcific tendonitis patients to doing their cuff strengthening merely in the isometric planes to begin with, to try and limit any further irritation and potential growth of that calcific body. So if I'm working on my flexion extension, that's going to be at the wall, just going 5 seconds. Well, technically we need 6, so I'll tell patients to count to 10. A 10 count forward for 10 times, 10 count back, abduction, and then internal, or this is external, internal rotation. Those isometrics are going to be helpful when we're trying to activate the rotator cuff and keep it wrung out with the blood flow, but yet try to reduce any kind of ongoing irritation we have. The other thing is we do also see the ability to diminish the size of the calcific body using some of our PT interventions. So using iontophoresis as a way to administer acetic acid, which is essentially vinegar, through the skin can help to dissolve the calcific body. So these isometrics are often accompanied by some acetic acid iontophoresis treatment. of the calcific body. And then just to round it out, of course, as we do with most shoulder blade exercises are going to be a big part of it, trying to, again, minimize how much pinching and physical irritation we get from the calcific body. What tips do you provide patients to prepare for a rotator cuff repair procedure? Rotator cuff repair surgery is no light undertaking. So there are some things that patients can do in order to best prepare themselves for the procedure. I think one of them comes down to the household tasks. So I think a lot of people emotionally do anticipate that they won't be able to do a lot of the basic household things that they may have done before, like cooking or putting away dishes, things like that. So any kind of meal prep that they can do in advance would be really helpful. Also reorganizing some of their most readily accessible household items. So if they usually need to reach things from overhead shelves that would take two hands, trying to reorganize them to a chest height or a waist height so they can grab them with their non-operative arm and bear hug it instead of needing two hands overhead. That can be really helpful as well as the meal preps. It can also be great to remind them that getting dressed is going to be a whole different entity. It's really difficult for a lot of people to pull clothes over their head. So maybe having your patients prepare with some button-up shirts can be helpful. Not everybody has those at baseline or might just have one. So if they want to wear more than one shirt for the next 6 weeks, sometimes having a few extra button-ups in their closet can be helpful. And then the other thing that comes to mind is sleeping. So a lot of people post-op rotator cuff repair end up sleeping in a recliner or semi-upright, which may not be something that they have set up in their home at baseline. So just considering where they might be most comfortable to sleep after their surgery is another great thing to kind of conceptually plan for before that big day when they come home post-op day one.